Okay, good afternoon, good evening, or good morning for those following us from the Americas, and welcome to this session on vaccination session planning, an overview of WHO session planning tool. Today, we are happy to welcome our guests to discuss this topic, and this session is presented in English and interpreted into French. To follow the session in French, please go to the bottom of your window. There's a globe. Select I think the title is interpretation. Select the language French, and you can even cut the original language so that you can have more comfort to listen to the French without the sound of voices. And this session is recorded and will be shared by email, and the presentation as well will be shared by email. And during this presentation, you can ask all your questions in the question and answer box. They will be answered after the presentation, by Solo, Maricel, Claude, and Abdoulaye. And I think that's it. I'm going to explain in French briefly how to connect to the interpretation. Pour vous connecter à l'interprétation, vous pouvez cliquer sur le lien sur le globe qui se trouve en bas de la fenêtre. Choisissez français. Vous pouvez aussi couper la langue d'origine pour ne pas entendre les voix des panélistes et pour entendre uniquement l'interprète. So thank you very much, and I give the floor to Claude. Claude, the floor is yours.
Thank you, Alex. Good morning, colleagues, and thank you for joining this session. We are talking about the session planning for immunization, and this tool is coming in a good time because, you know, vaccination is key intervention to save life. And to have this session vaccination organized, we need vaccine. And to have vaccine, we should improve our supply chain and the management of vaccine. And the best way to ensure that vaccines are available is to utilize vaccine in the way that we avoid wastage. And the planning immunization session is based on the reality of a country, on how they are using a vaccine and how the wasted rates for vaccine could be taken in consideration in the activity. We cannot avoid wastage of vaccine, but we should take it in consideration. This is why we are talking today about this tool developed by WHO on how countries can better plan their immunization session and use this tool to optimize utilization of vaccine. This session will be led by Suleiman Kone, which is our colleague in WHO HQ, who will be presented this tool to us and then conduct us through the different sections of the tool and provide some information on how to access the tool. And if countries have interest on utilization of this tool, we remain also available to support country for further information on how they can use this information. Thank you. And I give the floor now to Solo for the presentation of this vaccination session planning. Thank you, and over.
Thank you, Claude, for the introduction, and Alex for the support you're providing with the interpretation here. Welcome, everybody. And today's session, as stated, will be on the vaccination planning, and I will be providing an overview of what WHO tool is. Next slide, Alex. So somehow I already tried to put this slide here. It's just for your information, just to remind in which context now we are implementing the immunization as all in the Immunization Agenda 2030 and the Gavi 5.0. And both these big initiatives, these global initiatives are mainly just to, of course, reduce the mortality and the morbidity of vaccine preventable diseases throughout the life. And especially the need that to not leave no one behind and increasing the equitable access and use of the existing and new vaccines. And in that, ensuring the health and well-being of all by strengthening the immunization in the primary health care and contributing to universal health coverage and sustainable development. This is Immunization Agenda 2030. Gavi 5.0 priorities for the same period, 21-25, are aligned with the Immunization Agenda, of course, the goal and for ensuring the equitable access to vaccine by reaching 0 doses, specifically children and unmet community. So you see that in this program, in this new initiative, to achieve that, somehow you have to implement the services in a way that you can achieve those objectives. Next slide. And I remind again here other initiatives that were previously the red, what we call reaching every district with different declination that people are saying reaching every child and so on and so on. Those were initiatives that were trying just to reorganize the immunization component in order to reach really everyone. And if you look at the tools RED initiative have developed, session plan was one of the key tools for these strategies. And it provides a table that will be displaying the facility session frequencies in terms of numbers, especially per week or per month. And establishing these frequencies of sessions should be supported from the efficiency perspective, meaning that reaching high and equitable coverage, and also keeping the vaccine consumption at a minimum level. And of course, this should be able just to be delivered by the existing workforce at the health facility. The key principles here were that the population will be showing up for the vaccinations as per the communicated session plan that is at the facility. And also the second principle is that any eligible target present at a session will receive all the eligible vaccine for that session. Nobody will be turned out saying that, oh, no, we don't have enough people just to vaccinate. So these are the principles that will guide in that. Next slide. And then came here also to provide more precise information on session planning frequencies. And I'm referring here the immunization in practice. That was a WHO guidance document that was also published. You can see here some fragment, and the link is at the bottom of the slide, if you can go and see it. These were just getting into details of what is the different element that should be included in that session plan. It's going from the list of the communities deserved by the facility, the distances to the health center, the total population, of course, the type of session, be it fixed or outreach, depending on rural, usually it will depend on the distance of the community from the health center, or the travel time needed for the, depending on the terrain and the difficulties that to access. And for urban communities, this may depend, depending on the local context, on the social factors or convenience for the group being targeted or served. And the frequency also will depend on the number of children expected at each session. And this number will be derived from the total population of the community to be reached. Next slide. So the IIP also provide again exactly how the rough indicators, indications that how the session can be established depending on the population of different communities. These indicative session frequencies are presented in such a table you will find in the immunization in practice. An example I've given here, for example, for a population of 6,000 habitants, and an immunization team with 2 vaccinators, probably the 2 sessions per week will be every 2 weeks will be established. If you have now half of those population of 3,000, for example, with 1 vaccinator for the vaccination session, the frequency should be monthly. And if less than that, let's say around 500, a quarterly session will be planned. And some of the key principles behind those figures were provided here in the box, the text box we have put here. The IIP immunization in practice was stating that a reasonable workload at about 30 infants per vaccinator will be a sort of a threshold based on which the number of sessions and frequency will be established. And also this maximum accepted workload per vaccinator may vary depending on national immunization schedule. If you have more vaccines, of course, more vaccine with injections, it will vary. And also the vaccination policy and strategies adopted in the country. Next slide. So there were some issues with the IIP guidance. So first, it was just established here that regardless of the vaccine characteristics, so if we have, depending on the number of doses per vial, you see that in those guidance material or guidance indications of the IIP, there were no reference of that. So that it will not adjust the number of sessions based on these number of vial per number of doses per vial. And also, it will not account for the status of multi-dose vial policy that allow the reutilization of open vial during subsequent sessions. Therefore, in many places, those indications have become more a bit challenged by the wastage, the high wastage, when these were implemented, the session plan was implemented. And this has led, this fear of wastage has lead to some undesired factors that health workers have started doing that, for example, intuitive measure by health workers to try to minimize those wastage. And those measures were expense of the vaccination. And also the national instructions provided at the national level sometime saying that, okay, we are providing supermarket vaccinations, or all the facilities just vaccinate twice a week, or daily vaccination. These were challenged by this threshold, and then ignoring the specific context of each facility, because facilities are diverse in the same country. And then it has come that if you know in advance, if there's a possibility of knowing in advance the anticipated wastage, when and how, what will be the magnitude when you are planning the session, it will be a good indication for the health workers just to be implementing in a serene manner the vaccination. And this is exactly what the WHO session planning trying to provide, this sort of guidance derived from evidence-based planning sessions that you know in advance what will be the wastage based on the frequency you are established for each of these vaccine vial size or vaccine type. And then you can serve these outcomes or output from this tool also to measure your performance in terms of wastage when you are implementing the services. So this is really the problem we are trying to solve with the tool. Next slide. Now we are going to just give a snapshot of the tool. Just providing here, if you have a tool, first of all, it is an Excel-based tool that is designated for defining the most suitable vaccination session frequency from the vaccine wastage output and vaccine demand. So if you say that, okay, I have this type of vaccine, let's say measles, 10 dose, 5 dose, or 2 dose, if I'm making my frequency of sessions daily, weekly, or monthly, that will be the wastage I will be expecting. So this is the purpose. And then the purpose, of course, it will conduct the assessment by providing different scenario options, different session frequency can be put and see the output. And the decision will be now for the facility or the district team just to decide, knowing what are the outcomes from the tool, then there will not be any more resistance of implementing the plan session that have been agreed upon. And the utilization or the applicability, we are expecting that the session will be supporting district microplanning and vaccine forecasting, because it provides the vaccine forecasting based on how you are implementing the vaccination in your country or in your facility or in your district. There are a couple of principles here behind the tool. First of all, the frequencies is established for each vaccine individually. You are not saying that, oh, all vaccine will be provided at the same session. You take a vaccine, one vaccine by vaccine, and then you put, and then you assess the different scenario of frequency to select the most suitable one. And also the principle is that the impact on the vaccine demand and wastage are considered now in establishing the frequency, as we have seen previously. Another new thing that we see here, that the vaccine key input that are required to put in the tool are listed in the second text box. We have the number of doses per target. Each vaccine has BCG. We know that this is 1 dose per child per target. Measles, some countries have introduced second dose measles, so those countries will have 2 doses. Pentavalent and PCV, those vaccines we know already that are 3 doses in the schedule. The second characteristic is the vial size. The vial size is expressing here in the number of doses per primary container per vial, let's say. And the third, finally, is the status regarding the multi-dose vial policy, how this particular vaccine I'm planning for or I'm going to use, if the open vial can be discarded, should be discarded at the end of the session, or can be reused during multiple subsequent sessions up to 4 weeks, as the policy has stated. Next slide. So by doing that, we present here some of the examples just to see that how the session frequencies really impact on the wastage and also in the vaccine consumption, the vaccine demand. Putting here one method, the standard method, okay, not standard, the initial method we are all using sometimes when the country are using the traditional one. If you have a vaccine, immediately the only thing that people are asking is that the population, the coverage, the dose per target, and the wastage that is stated. And here there were a lot of confusion or a lot of misunderstanding for establishing that wastage. Over the past years, people have been in general just applying that, oh, BCG is that 50% wastage. And sometimes they were saying even that WHO standard. It's not WHO standard. So 50% systematically people are just using that. If you apply that method, you see that here the estimated annual need will be 640 doses, right? So now, if we take now the new approaches based on the session planning, we have put here three scenarios. The first is that weekly session, so one vaccination a week. The second, it will be 3 sessions in the week, and daily will be 5 sessions in the week, all the days. And you can see that the doses, the annual estimated need will dramatically increase up to 7.6 times the first method that we just use 50% wastage rate. Yeah, you can see here. For weekly session, you have 980 doses for the same facility. If you are using 3 sessions per week, it will increase to 2,940 doses. And if you are making daily session for that facility, you'll have 4,900 doses. You see how it matters. So now, as you have this here, you can then see that the way you plan your sessions, you can decide accordingly based on this output. Okay, if you agree and this is accessible to you, if the minister is saying that our policy is daily vaccination, so they should accept also to give you the 4,900 doses and not 640 doses. And then we have put here in the other 3 columns, 3 rows, trying to change for the first method, the wastage from 70, 80, 90 wastage rate. You can see how it increases, even though you see that it will be difficult just to apply the first method by trying to guess what will be the output from your forecasting processes. So the best way is that to have the sessions. If you have the sessions, you can have exactly the number of doses that are anticipated, and subsequently the wastage will be calculated that are not necessarily presented here. Next slide. So the previous slide was just for the vaccine where you don't reuse the open vial, you discard at the end of the session. This slide now is showing that the same example, but with at the bottom, you see that we have different duration of reutilization of an open vial. We say, let's say the WHO standard is saying that up to 4 weeks under the specified conditions, that is at the bottom. But some countries are saying that, okay, we have some challenges of not ensuring the non-contamination of open vials, so don't we reduce that duration, only keeping at 3 weeks, 1 week, or maybe sometimes countries say that we don't, even if WHO is applying, the condition does not permit, we don't use it. And this table is showing that how much you are losing actually. You see that if you are applying these sessions, this policy in the halfway, you will have a vaccination as compared to the discarding. This is 4,000. We are looking at the last column, the daily sessions. Even if you try to use this for two weeks, reusing the vaccine that is eligible for 2 weeks, the open vial, you will reduce your consumption by half. And if you are applying fully the 4 weeks, you will reduce it. You see that 3 times or even 4 times less. So this is just to show you that the session frequency will provide you with all the details, just with all the information, the evidence that you can just then decide, knowing the results of the impact of the session you are selecting, just to establish, to agree or not, or change the session you are anticipating to plan. So based on these, the results that you are seeing here in the calculations. These are some of the calculations you will get it. Now let's go now how you use that to get these. Next slide. How do you get that? The tool, as we said, that is Excel based. The first thing that it starts with the vaccination schedule. And we have put here, this is, you select in the column B, C, D, E, up to K, all the detailed information that are required. The B will be, you'll be listing all your vaccines, and the column C will be, you specify if the vaccine is routine or for supplementary activities, SIS, or any campaign vaccine for, we have put here for this example, COVID, some COVID vaccines. Then column D, the number of doses per target. And the column E is the specific target group. be it live birth or surviving infant or pregnant women. For SIS, there's no, you can just type a free text here. It can be just elderly over 65 years or frontline workers or any comment you can put here. The other I just drew down this for the routine. And then the column F will provide you what is the percentage of this target in the total population. As you can see here, 4.5, 4.4, 4.1. For the SIA COVID, you have 60% just of the total population to be reached. And then you have the coverage in the column J, and you have the doses per vial for the vaccine that you have put in your immunization schedule in the column hash. Column I is your indicative wastage, what the policy is stating. You see here BCG the 50%, BOPV 20, etc., etc. And the column I and J and K will now you select what type of syringe for administration and syringe if needed for dilution. This is just to calculate. Now this syringe will be calculated automatically based on this column, two columns you have fill out. From column L to O, these are automatically generated for the database. You see that the multi-dose vial policy, you see that 0 means that you discard. 28 days mean that in the WHO database, the pre-qualified list, this vaccine can be used up to 28 days, mean that 4 weeks, but you can decide either way. These are nominal information, These are nominal information on the vaccine characteristic. Administration is intradermal, oral, and so on, so on. And then the nominal storage temperature is given in the column N, and the volume of this per child or per target is calculated. Next slide. The second information you have to fill is the structured list of your facilities. These lists are available in all the programs. I can say you have all conducted the cold chain inventories. The same list. You have conducted the EVM assessment. You have made the country setup. It is the same list. You have your immunization reporting system. It is the same list. You have the DHS2. It's the same list. So you don't reinvent the list. You just reorganize the data based on this column here: province or region, district. The structure means the health facilities, including the district health team and the state level stores. And then the next column E is the type of facility. Mean that these are, we have adopted here the EVM categorization. SP meaning service point, LD means district, lowest distribution level. SN, you will see that SN will be subnational, and PR will be the primary, which is the national stores. Active means that if it is active or not, it will be, this will be 1 or 0, 1 or 0, 1 or 0, and the total population and distance to the supply. All these information exists already in the file or the information through the database you have already. This is the second list to be filled out. Next slide. Once you have filled that is finished, the third portion you have to fill is that your national or your provincial or your district instructions of number of sessions per week for each of the facilities. So ideally, this should be filled out during the district micro plans, where all the facility members are coming there, and they have the list. You see that in the column D, each structure we say that, okay, district manager, we say that the instruction from higher level now is BCG is just, these are just examples we are giving, because everything that is yellow here means that it is subject to change. So once a week, BOPV is 6 days a week. Maybe this country is working for 6 days a week. Normally it's 5, but we have put this 6 here. Penta is 6, IPV is 5, etc., etc. MR 2 days a week. TD is 5 days a week. Yellow fever, etc., etc. So you plot here as the instruction, as the immunization frequencies are set by the higher level, can be district, it can be the national policy. And then now you get the calculation. So anything you enter now is finished. So you start with the schedule, the list, and then how you put now for your own facility or at the district level. This can be plot here, this section. Next slide. Once you have done that, the same in the subsequent columns on your right of the session, different session frequencies, you will have now the estimated anticipated wastage rate for each facility. You can see here for BCG 78, for BOPV 29. I'm just reading few of them. And from column AY, you will see that the estimated annual demand, in that what will be the vaccine requirement for the year for this facility. These are the output from the session frequency you are established, the number of the vaccine characteristic in your schedule, and your population. Next slide. Now you will see that if you continue, you see that in this also you have the estimation of the number of syringes required for injection annually. You see that the first column AK is a syringe for BCG for each facility. The total dose required will be coming automatically calculated for each facility, and for the district the total will be made and readjusted. The syringe is 0.3. We have put that because new vaccine, this not pentavalent, which vaccine has used it? COVID, yeah. The COVID Pfizer vaccine is using that. You see that none of this vaccine is yet COVID for routine. It's not calculating here. And then 0.5, this is which is most of the other injectable vaccines. The total syringes will be calculated. And also from AN, you'll be calculating the number of doses required for deletion. 2 ml, 5 ml, 6 ml, and AQ will be calculating the number of safety boxes required for each health facility. And subsequently, the green cells headings will calculate the total cost. Based on the cost of your vaccines, we have used here UNICEF weighted average prices, and syringes deletion. You see that the cost here for this facility is $180 per year. The total for this is $1.45 thousand for all the injection supplies and the vaccine cost, and the total cost will be calculated in the last column. So just by putting your initial sessions, you have all the calculation that is made for you. But you can say, oh, I'm not happy with the session plan that was dictated from national level or provincial level or district level. We have some exemption because we have in the specific context. Next slide, you will see how you can do that. Next slide. No, sorry. Yeah, this will be, once you've done this, go back, sorry. Go back again. I'll move this. If you have this here, this is just the summary of all the facilities. Next slide. So now each facility from the district microplanning will have a summary table like that summarize all their session vaccine forecast based on the session plan agreed, if any. So you have just to select here where you have the structure in front of the cells in front of that, a drawdown list that we select for each facility, and the calculation will be made here for routine, and at the bottom for SIAs, and the total will be made for you. Going for putting all the vaccine, the targets, the population, the doses per target, the sessions per week. You see 1, 6, 6, 6, 6. doses per vial, of course. The multi-dose vial policy here in weeks. The 28 days will be converted into 4 weeks. The mean session size. So what is this average session, average doses anticipated to be vaccinated, to be delivered, administered during each session for BCG, for example, and for each vaccine? The anticipated wastage, you have 79%. And then the annual doses, the monthly, if you divide it by 12, and then you have the monthly. And it will calculate also based on this, the safety stock, how many doses you have to keep in safety stock. And it will calculate, convert these two, all these into dollar value. So you have this summary can be printed for the facility and put in their plan just to monitor and then to seek for the resources. Next. Same for injection supplies or injection equipment. You will see that it will calculate the number of syringes by typology required and the cost associated with, and the total of routines, SA, and grand total is made at the bottom. But as you can see, that next slide, you can still make some, granular assumptions. So, okay, I'm not happy with this. How we can do? Next slide. You can take now, there's a special sheet that is, we call it simulations. You select your facility service point. You select the vaccine. By default figure will come in the white cells, but the simulation, you can change those figures and you put here in the table, the input to the frequencies, 1 week, 2 weeks, 3 weeks, 5 weeks, and it will calculate you the result. You see that the total and the estimated cost here, though you can decide now, or I'm going to make three sessions, 5 sessions a day, a week, or 2 days a week, or 1 day a week. And then by comparing, now you can now select, knowing in advance what is the output. Next. And then subsequently at the bottom of that table that we are showing in the previous slide, it will calculate you the open vial wastage in the first small table and total wastage, including closed vial wastage, that is set at 1% normative. It factor the two and then give you the total wastage anticipated at the bottom small table. Next. So this is just the summary. As you can see that the tool provide, the tool really is providing outcome in 3 areas. The policy setting, by anticipated wastage rate, it informs the choice of the vaccine vials, vial size, and vaccination session frequency, and helping the facility at the facility level to match the expectation with the policies. The second is the adequate supply. It ensures that because it supports national vaccine forecasting on the rational basis on how you are implementing services, it will calculate the vaccine need subsequently. And it establishes also the appropriate safety stock levels. You know that we all know that we are just estimating, safety stock is, it's 25%. But it's based on what? This tool will give you the rational, what is the appropriate safety stock level. And then finally, it be supplying the adequate quantities based on the forecast, adequate quantities to supply all the levels. And then at the service delivery, it will really facilitate by assessing the organization and the implementation of services according to the plan. You plan what you do and you do what you have planned. And then you monitor the service with consistency of data. I think that's where I have Alex and Claude. Maybe questions. Thank you.
Thank you very much, Solo. I think it's time for the questions and answers. So there are a few. I will give the floor to Abdoulaye, who will moderate the question and answer session. Abdoulaye, the floor is yours.
Thank you so much, Alex, and thank you, Solo, for this good presentation. At this point, we have just only one question in the Q&A box. And the question is from Masaret. Masaret would like to know, are you trying to link with the NIS estimating of vaccines and supplies starting from microplan to higher level in order to have realistic estimates? And he has also a suggestion from him. Masaret suggests to take this forward, as many new staff have joined at country level, it will be good to hold session from the API managers in order to answer they attend to the webinar. Solo, you have the floor.
Yeah, I think I cannot not agree with Mesret. Maybe Claude, you may, since I think the strategy WHO, we've tried here that by working with our colleagues in the regional level, try to put together, because of the challenges, trying to provide the tool and then the dissemination. I think this is the start of it. And each region will be different, each country will be different. And I think that maybe Claude, you can intervene here.
Yeah, really, we thank Mesret for questions. And yes, we take all opportunity to inform API managers about how to better planning sessions for vaccination. And this tool is interesting to them to organize or to plan the session. And this could be discussed within this next coming API manager. But the countries that have interest, we can also try to engage with them and work with these countries on how to utilize the tool. This is also opportunity that we can provide to countries. Thank you.
Thank you, Solo and Claude, for your answers. A second question from Dauda. Dauda would like to know, he said that it is clear that what said during campaign is higher than during routines, and how we reconcile this when making our forecast.
Okay, thank you, Dauda. I think the wastage, this is a bit something that is, we think that the wastage during campaign must be lower than the routine. Why? Because from what assumption? The wastage depends on a couple of factors. As you can see here, it depends on the vial size. So if the routine and the campaign you are using the same vial size, so this factor is equal. The second thing is the session size. Session size means that the number of doses anticipated per session. So campaigns are time-limited interventions where you have many people that you are getting vaccinated. So while the routine is a broader distribution throughout the year, where you have small people are coming at the vaccinations, intuitively, and the calculation will show that the wastage during the campaign, I'm not saying that when some specific areas where the campaign is door to door in the very sparse and remote areas, the wastage should be lower than the routine, definitely. Your experiment may be showing otherwise, and then the narrative should be put to describe why we are seeing that the campaign wastage is higher than during the routine. Why? If it is, I'm talking about here of the open vial wastage. The wastage may be higher because of you have some challenges with the closed vial wastage. Maybe during the distribution, you have many vaccines that are getting the labels removed because of you are involved in many handling of the vaccine. Yeah, that can increase the wastage, but this is not the open vial wastage. You may, for COVID, we are seeing that there's many countries have experience of high wastage in closed vials, but this was due to uncertainties in the shelf life. For example, you receive the vaccine with very short shelf life, and then when this established short shelf life is reached, you have to discard the vaccine because this is the knowledge you have. So this is what I can say here. You cannot say in advance that the wastage is higher with campaign than routine. The second thing here in the tool, you plan also in advance the wastage for the for the campaign by plotting the workload. We know that in most of the micro plans, we know that to calculate the number of teams required, you say that how many vaccinations a team can give a day. This figure is actually more than the routine session. We say that for polio, I think at the time we were planning session for polio for it was 80 kids per day. For measles, some teams can vaccinate up to 100, 120, or even 200. So you see that if you are using 10 dose vial here, so the wastage cannot be higher than routine, where you are vaccinating much lower kids. Maybe Dauda can also elaborate more on if I have not addressed his point.
Thank you so much, Solo, for this answer. Another question from a participant that I don't see his name, but he asked it. He noticed first that he saw 50 and 79 wastage rate for BCG in two different tables, and his question is that may he know why it is so.
Thank you. Okay, I see this anonymous attendee. Okay, thank you. I think this is a good question. You know that in most of the places when we are planning our vaccine forecast, BCG, we just say, oh, BCG normally is the 50%, or many countries in many places, people say, WHA say that it is 50%. This is the mistake we have been doing, and we want to correct that. You cannot just state the wastage in advance unless you are getting from your historical data. Even historical data will not sufficient because you may change. Last year, you were making 1 session a week, and this year, the minister say you put 2 sessions a week. You see, so historical data on wastage can be used only if everything is equal as last year. So the 50% was set without a rationale on the exact implementation of activities. The 79 now is calculated to show that, okay, I'm doing 1 session a week with these 20 dose vial with this population, and I'm anticipating, because you can calculate, if you are making 1 session a week for 48 weeks, how many sessions you have during the year, you calculate, and how many kids you have to vaccinate, you know it. If you divide the number of doses to be administered divided by the number of sessions, you have an average. Let's say 4.5, maybe 5 doses an average. So based on that, you can calculate the wastage, and it cannot be, maybe sometime it can be 50%. Then probably you got it, you guess it right with your 50. But in most of the cases, it will be different. So the session planning is based on the factual element of your plan. So I'm doing 2 times a vaccination session, then the tool will calculate the total number of sessions during the year. If you are making every week 2 days, multiply by 48, let's say 48 weeks in the year, just to vaccinate 300 kids, You see the average, how many kits will be per session. And then this will give you a wastage. That's the difference.
Yeah, thank you, Solo. A question from Usman Ja. Hi, Usman. And the question from Usman is that is the buffer considered using the tool?
I cannot see the question, sorry.
Yeah, he asked that. It is related to the question from the Wastage. So Usman would like to know if the buffer is considered using the tool.
Okay, the buffer here, we named the buffer by the safety stock. This, at least in this context, this is the understanding. The buffer is calculated how? You know that if you have an average, because the calculation here is based on the average. If you are an average, you will have the total dosage to be administered divided by the number of sessions, you get an average number of doses to be administered per session. But statistically, you will have some sessions where you have more kids than the average. And these statistically, how many sessions will have out to how many as compared to the average? This is the safety stock, because you will have half of the session will have less than the average, and you have more than the average sum. And the safety stock is calculated based on what if you have a session that are more than the average up to 2 times. It is calculated based on that. It is some complex statistics. You can, in the document we have put that, you will have the details on that. Usman, maybe the time is long just to get into those explanations here.
Thank you so much, Solo. Maricel, I think that you want to add something, right?
Yes, no, I just want to highlight that the critical message that this tool wanted to sort of communicate is it supports the principle of the tailoring immunization session. So we are trying to get away with the normative guidance that was presented by WHO earlier, but we really want countries to really use the available data that they have in order to guide how they are planning their immunization session, because it also affects how they will forecast their supply and how they will utilize their supply. But of course, it doesn't mean that we will sort of accept just if there is a high wastage, but it's really we also have to think that in the practice in the field that when a child comes, there is sometimes a hesitation to open the vial because it's only 1 or 2 children and you have multiple doses vial, multi-dose vial. So we also wanted to, at the same time, not lose the opportunity to vaccinate children, but really plan your session using the data that is available to you in the local context, so that you can plan your session in such a way that you are not risking missed opportunities. You're really trying to increase your coverage, but at the same time, you are minimizing your wastage. So this is basically what really the tool is sort of also the intent of the tool is to really guide health workers to have a tool that will guide health workers in optimizing the immunization session as well as the available supply that they have.
Thank you, Maricel. I think this is good. Dauda has come with a very good question. Okay, say that as now different from level to context to other. Does this mean that there is no more acceptable benchmark subsequently? Okay, there is, but there's no subsequent, there's no acceptable bench that is acceptable for everyone, you know. It's not that for each specific context, there is a benchmark that you decide to accept because you can afford. Let me explain. I'm not sure that is, I have explained it clearly. If you have in a health facility with your district microplanning, you find that in the 5-day daily vaccination of BCG is getting very high consumption, very high wastage. But the program cannot afford to give you that such doses. Yeah, we agree that is fine, but then you have to revisit to unacceptable, and this to a threshold where it is affordable for the program. Because the session, if you plan any session frequency and you communicate to the population, to your community, and you stick to it, they will come, unless it is just something that they can afford. So you see, the acceptable level is the level that is affordable by ensuring the satisfactory coverage, equitable coverage. Meaning that the 25 wastage for measles will be acceptable in my health facility. That is a benchmark from my calculation. And now that for you, 75% wastage will be acceptable in your context. Derived from, this is the only way I can just reach the population and my program can supply that vaccines. You see the two. It's a very good question, and then we can elaborate more maybe at a time, but it is an essential question that is we're trying to solve here. Thanks a lot.
Thank you so much, Solo, for your answers. And I think that was the last question we have in the Q&A box. Alex, you have the floor now.
Thank you.
Maybe, sorry, before Alex, there is one question from Leonard Badibanga. He's asking, this tool is facility oriented because it's more operational. So how the central or intermediate level should use this tool, how they can do. And I saw also Usman has his hand raised.
Maricel, I think, can you just talk about the wastage calculator that exists also for national level and global level? So this is a very good question, Badibanga. How UNICEF or here Gavi we can make for all the countries? We cannot use that. We cannot use this because we don't have the list of facilities. The national level, you cannot wait until all the health facilities get you the information, for example. It's a very good question. There's another tool where you have some other assumptions based on the knowledge of your health facilities in terms of how many health facilities are vaccinating daily, or proportion of facility providing daily sessions, proportion of facility providing, let's say, twice a week, proportion of facility providing monthly. If you have those information, you plot those information in those tools, and you get approximately, and you will be very close to your national wastage. That will be used in your vaccine forecasting, but not just say, oh, 50%. No. The vaccine calculator will calculate you what will be most likely the wastage you are anticipating you will be getting in my country, knowing that, okay, 10% of the facilities are daily, 60% are weekly, and then 30% are monthly. But you have to have those information. If you don't have anything in your services, it will be difficult to anticipate the wastage. Or you can say, okay, well, I have conducted vaccination wastage study for the past 5 years, and this is for this particular vaccine, the wastage I've been systematically getting. And also, I'm not planning to change the vial size, because if you change it from, you were using 10-dose vials, and then you change now to 2-dose vial, those wastage study result will not help you much because it's completely different vaccine presentation. You see, but I'm assuring you that there's another tool, Maricel will communicate to you, the WHO vaccine wastage calculator that will help you to calculate that. And I think we'll give you the link in the, I don't know if the link, Maricel, you can see if we can give the link later on.
Yeah, so anyway, the presentations for this webinar will be shared. And once this is, the recording is made available, we will also share the link to the tool so that you can utilize the tool. You can explore and decide to utilize the tool. And if there's any technical assistance that you would need from WHO, so Claude is our focal point in the AFRO office. If you're interested, please express to Claude so that we can see where we need to provide TA and where we need to provide further support. So this tool that Solo mentioned, the one that is used for national level for determining national wastage rate based on historical data, is a complement of the session planning tool. Formerly, we call it district wastage rate calculator, but it's not just, as you know, really a calculator. It's really a management tool that will benefit both the supply side and also the immunization side. And this tool aims to encourage coordination between the two because this is key, one of the key factors to make to make a stronger immunization service delivery. So we hope that that you are now familiar with the tool and will be interested to use the tool. And if anything that is needed from our side, if you need any support, kindly please let us know through our regional focal point, Claude. Thank you.
Merci Maricel. Donc, si vous permettez, Solo, il y a une dernière question en français. Donc, qui doit réellement utiliser cet outil? Est-ce l'agent vaccinateur ou est-ce le médecin-chef de district?
Une très bonne question. Can I, Alex, shall I answer in English or?
In English, because there is no French.
Okay, sorry. There's a very good question here that who should really use this tool? The district manager or the health worker, the vaccinator? I will say this tool is intended to be used during the district microplan. And this governs two of these stakeholders. During district microplan, you have the health, district medical chef, and you have the health worker that has also some idea on his communities, and the district has the instruction level. So, you combine the two and you agree on one. So the tool is intended to be used during district microplanning. And what is important here, don't say that, okay, I'm making sessions, how do you say that? Weekly sessions here in my plan. And then the next day, when I start implementing, the first women come and say, no, wait until you are 10, then I can open the vial. No, then this is completely wrong. You plan what you do, but once you have planned, do what you have planned. Otherwise, it will be completely a mismatch between the plan and the implementation. If you are planning now weekly sessions and you start postponing sessions, saying that, oh, we don't have enough people again. No, this was previously because you didn't know the output or the outcomes. You didn't know the impact. Once you have agreed that I will accepting 79% instead of 50. So accept the 79 because you know that this will be that. You see, don't plan something and do another thing. Merci beaucoup. Hein?
Thank you so much, Solo. Alex, I think that it was the last question.
Yes, thank you very much. And we need to wrap up because it's already 8 past. Thanks a lot for this presentation. Very technical and very useful for many of our participants. As we said earlier, everything is going to be shared. The recording, the presentation, I will speak with Maricel to see what are all the links that we're going to send you as well in the email that I will send probably early next week. Thanks again. Have a nice rest of the day, everyone, and a nice weekend. And we'll see each other for like another webinar pretty soon, hopefully. Have a nice day, everyone. Bye-bye.
Thank you a lot.
Bye-bye. Thank you,
Bye-bye.
Alex.
Thank you,
Bye.
everyone.
And thanks to our
Bye.
panelists. Excellent. Thank you. Bye.
Bye.
Thank you and the translation.
Yes.
Bye.
Merci à l'interprète. Bye.